Hello, everyone. Welcome to another morning VMR. Today, I'm very happy to be with you, to see all the team and see very familiar names here. I am very excited to tell you that today I'll be discussing with our dear Dr. Ravi. Hello, Dr. Ravi. How are
Good morning, fellow plant human.
you? Yeah, I can see you. I really like our green background, as Sammy pointed
Okay.
earlier. And I wanted to ask, does somebody have a case?
Oh, look who's here. Wow, two people I haven't seen in VMR a long, long time just like popped in simultaneously. Lev and Carolyn. Hello. Hi, Lev. What's up?
Hey, friend.
How's it
I actually,
going?
good. I'm on Jeopardy today,
Oh, you
so
are?
I'm working, getting some stuff done while waiting to see if I'm getting called.
Oh, fingers crossed. I hope you can stay the whole 30 minutes / the whole day relaxing at home.
Sounds good. I have a cool case too, if no one else has anything.
Oh, wow. Amazing. Okay. All right. Let's give folks 30 seconds or so. But since you're here so infrequently, we'd actually love to have your voice percolate the 30 minutes with Yasmin. Anybody else itching to present a case? I don't think so. Carolyn, are you able to unmute and say hi? I think it would be a treat for everyone to hear your voice again. It's been so long. If you can't, that's totally okay.
Yeah.
Hi. Good morning.
Yeah, it's so good to join again. I finally finished med school requirements. So
Congratulations. How does it feel?
feels great. Yeah. Got my match results. And so I'm excited.
Tell us where you're going.
Headed to Stanford for internal medicine. So
No way. Oh my gosh, you got to come say hi. Charmaine is here, I think, on the call. And as you may know, she's based at the VA there. And
oh my gosh, I'm so excited. I can't wait to work with you, Carolyn. I'll see you at the Palo Alto VA soon.
I'm excited. I've been trying to get my fingerprinting done and all the VA paperwork. So
yeah, good luck.
Classic. It's worth it once all of those things are done.
Oh, I know it will be.
It's a rite of passage. It's a rite of passage. All right. Lev, if you're still down, we would love to hear it. Rock and roll.
Sounds good. Why don't I just give the chief concern and let you riff? So this is a 90-year-old man with the chief concern of 1 day of rash and throwing up blood.
Yeah. What do you think?
Okay, so we have these two main issues being the rash and hematemesis. Before, like hematemesis could be definitely upper GI bleed, and the first thing I will think is, I would, before jumping into conclusions, like first ask for all the past medical history, if he uses any kind of medication, if he has, because what I'm thinking on could be a peptic ulcer disease, could be variceal disease, if he has liver disease too, that conducts us to a variceal bleeding, if it is any other a traumatic lesion such as Mallory Ways, Boerhaave, which obviously comes with past medical history, and now rash. I will also like to ask what kind of rash is this? Is this papules, pustules, excoriations, scaling? If it is erythematous, if it's pruritic, there are so many things between both of them. Of course, that in this case, I would definitely look first at the hematemesis because it could pose a more urgent issue. So I would start a protocol of like, if this patient is stable, if this patient doesn't require a transfusion, like a massive protocol transfusion and IV fluids. So yeah, what do you think?
I love it. It was interesting to see how you first went GI bleed first. You prioritized that because that's way more morbid. And I think it's so wise to divide presumed upper GI bleed into a variceal versus non-variceal. And then the rash, you're trying to study it before you put together a differential diagnosis. And in keeping with what Hans said, you want to analyze these two things separately and see if they are related. I can't think of any common scenario where a patient has an upper GI bleed and rash in a common scenario. So that either means we're dealing with an unusual scenario or two things that are unrelated. But the truth is, when somebody comes in and they're vomiting blood, you're doing RX much more than DX. And in this person, you want to have 2 large bore IVs right away. You want to type and screen them for sure, maybe even get their consent for blood. And the first thing you're thinking about is, do I need to protect their airway? And then move on beyond that. So we'll see if the tempo of this bleed is one in which we have to turn into the, not so much the clinical problem solvers, but the clinical fixers before we solve the problem. All right, Lev, tell us more, please.
All right. So history here is going to be a little bit more important. So he, elderly gentleman, lives with his family, completely like able to do his own IADLs, ADLs, and just notice that he had a little bit of minor leg swelling and a very dot-like rash all over his shins that crept up over the course of 1 to 2 days. And then you ask him more, and he actually has noticed some blood coming out of his nose. And also he's like, oh, I don't know if I was vomiting up or whether I was coughing it up, but it was coming out of my mouth. And it was like a teaspoon at most. It wasn't sort of that much, but it was really concerning and brand new, which prompted him to call his outpatient doctors. And then they said to come to the emergency room.
Ooh, intriguing. Yaz, what do you think? How does this data influence your thinking?
So now when I'm talking about, actually I had the same question as Caroline, like dot-like rash, just a petechial rash, definitely concerned about coagulopathy. I think the chat is like agreeing with me right now, because in a patient that has epistaxis, gingival bleeding, hematemesis, the first thing I would definitely ask for controls would be if there is any coagulopathy, if there is any previous episode of bleeding. And obviously, like, I think one of the controls that you have to do in a patient that has recurrent or even a new GI bleed is check for von Willebrand disease, etc. So that's the first thing I would ask for. And again, definitely see if there is any other overlapping syndrome or symptom or sign. But this is the first thing I will think, any coagulopathy or any issue that could cause a platelet dysfunction. Yesterday, Dr. Shermin was telling us, what if this platelet dysfunction can be because the patient is not creating platelets, or there is a consumption, or there is actually an issue, like intrinsic issue in the platelets. But then again, I think I'm jumping too far. What do you think?
No, I think you made the right conclusion that you're saying now it's clear to you what this problem is. This is a bleeding problem. And if you're trying to be very simplistic about a bleeding problem, there's really only 2 components to why people bleed. There's something wrong with the blood itself, either platelets or coagulation cascade, or there's something wrong with the vessel wall, the actual blood vessel itself. So that's the simplistic approach that we take. And the truth is we have access to understanding the blood very well with basic lab tests, platelet count, PTT, and INR. But we also have access to understanding if it's a vessel wall issue in this scenario by studying to see if the rash is palpable or not. Because if we call this palpable purpura, we make a lot of inferences that it's probably a vessel wall problem, and that's why you can feel it. So in this case, the exam will be able to tell us if there's a vessel wall, and the labs will be able to tell us if it's a blood problem. But I think this case is also a great reminder that hematemesis is not actually a thing. In your approach to hematemesis, you have to question the 2 components of that word. And the 2 components of that word are heme and emesis. And you always wonder, is it really blood, or is it some dark red substance that the patient maybe ingested? And you always wonder, did they really emesis? Is it really emesis, or is it hemoptysis, or is it upper airway bleeding? So I think in this case, we're more confident that it's heme or blood based on the fact that the patient also has some rash, but now there's question as to the origins of this bleeding, which I think is not uncommon. So I think the biggest takeaway, Yaz, from your conversation is how immediately you start to think about bleeding. And so this probably now is a systemic bleeding issue. And the key question is it a blood problem, coagulation and platelets, or is it a vessel wall problem? And your hand may be able to answer that to see if the rash is palpable, suggesting a blood vessel problem. And the lab tech may help you understand this with the platelet PT and PTT. All right, Lev, tell us more, please.
Can I show a picture?
Oh, of course. Let me make you co-host real quick.
Yeah, and I'm realizing that because I'm using an electronic medical record, the patient's name is at the top. Do you know of a way I can not show that with Zoom?
I don't think so, unfortunately. I don't know if there's a way that you can screenshot the picture itself.
Oh yeah, good idea. Let me just do
Yeah.
that real quick. 1 second.
Okay. Yeah, there we go. Maddie is oh, Sarah knows how to. Oh, wow. There are a lot of great suggestions in the chat. Mine was very basic. Sarah, Leah have some more higher order suggestions.
No, I just took a screenshot, so that'll be actually, I like
Okay.
that suggestion. It'll be
Okay. Oh, there's there. I gotta make you co-host still.
all right. Let me know when you're ready. Can I do it?
There you. Oh, sorry. Now you're ready. Should be good to go.
Can you see that?
Yeah. Yeah. What's your reflex here?
The first thing I am thinking, it looks like purpura.
Yeah.
I am definitely thinking about that. It doesn't look it. That's my first thought. Please correct me if I'm wrong. And now I'm thinking my first thought would be which coagulopathy could this be causing? Because some of them, like there is the ITP or the IC or TTP that may come with purpura. So I try not to anchor. Yes, it also looks I'm between actually purpura and petechial. Again,
Yeah.
my first thought was purpura, but then again, this is like my two options. And the first thing I would look at is definitely controls, like and blood smear again, controls and blood smear, because if there is schistocytes, we would be more into TTP, HUS, DIC. If there is obviously all of them will have consumption of platelets, but also I want to see the PT, PTT, and try to work around that. Because if it's not blanching, then yes, I will definitely think between petechial and purpura. What do you think?
Yeah, no, I think the distinction between petechia and purpura is simply how much there is. Petechia are pinpoint and purpura is more extensive. And I think both of them share the fact that they should be non-blanching. And so there's two things about this rash that you can only deduce with your hand. One is, does it blanch? Does it go away when you put pressure on it? And two, can you feel it with your eyes closed? But I completely agree with you. This looks petechial. And the question is it truly petechial? Press on it to see if it goes away. If it doesn't go away, it's petechial. And then can you feel it? Is it palpable? Those will be two helpful things. What did you find, Lev? What was your
it is not blanchable. Not really. You can't really feel it.
Okay.
But it's definitely not blanchable. Got it.
So it sounds like we're saying it's not blanchable, so it's petechial, but we can't feel it. So it's non-palpable petechia or non-palpable purpura. Okay. All right. Do you want to give us more information?
Sure. So in the emergency room, initially the ICU triage folks were called, but the patient sort of stopped having too much blood coming out of his oral cavity. And so he ended up being sort of admitted to medicine. Let me fill in the bottom left corner super quick. His past medical history is AFib and CAD, now on I think as Pixaban, I forget which one exactly, and hypertension. I think he had some gout too and was on allopurinol and some hypertension meds. I don't remember which ones. No family history of bleeding disorders. Lives with his wife and son, and no recent travel or new exposures or anything else like that. And I don't think he had any allergies. By the way, I'm still, I think I'm still host in case you want to switch that back to you guys.
Yeah, we see the whiteboard now.
Sounds good. On exam, he was in no distress, joking with all of the team. His vitals were a heart rate of 80, blood pressure 120/80. He was satting 89% on room air. Respiratory rate was 16. and he was afebrile. He was like a super jokester guy. In general, he had no bleeding in his mouth that we could actively see. He had mild pallor of his conjunctiva. Heart exam was irregular, normal rate, no murmurs. He had bilateral crackles in the anterior fields and asymmetric crackles on his back. His belly exam was soft, non-tender, neuro oriented ×3, non-focal whatsoever. And he had some various bruises across his arms, but no other similar petechio rash anywhere else.
So
Let me know if you want the labs or just stop here.
Yeah, maybe just for the sake of time, you can give us the initial
Cool.
set of labs.
I'm going to make a bunch of this up. His
please.
white count was 5. His hemoglobin was 10. His platelets were 0.
Okay, all righty.
His chemistry panel was fine. Creatinine was actually, sorry, I misspoke. His creatinine was 1.5 at his baseline, and I forgot to mention CKD before.
That's okay.
Liver stuff was fine.
Fascinating. So yeah,
And then do you want imaging too, or should I stop?
I think this is great. A great point to stop.
Okay.
So Yaz, what would you say now is the problem you're trying to figure out? Well, how would you summarize the
I
problem
would
at hand?
definitely think that with this being on the rash and the bleeding are main concerns, and after looking at these labs, like especially platelets being 0, I'm thinking that it's an intrinsic problem of the platelet. Now, I would definitely love to see if there was a blood smear, but before we jump to that, I would think, well, maybe this is the reason for this patient to have 0 platelets. Could it be that these platelets are not adhering to the wall, they have an aggregation disorder? If there is an antibody that's destroying these platelets, I'm thinking, how are their kidneys? 1.5, I see it. And definitely see if, I don't think that the apixaban could be causing this. It's a factor 10 inhibitor, if I'm not wrong. And those have like a therapeutic, I forgot the word in English. Like they are, it's not as the therapeutic dose, it's very difficult to get over it. I forgot how do you say it, but the thing is, with all this information, platelets is my first concern. Like there is something going on the platelets, then I would ask to see if there is anti-platelet antibodies, or if the platelets are deficient by themselves.
Yeah, I completely agree with you. I think the core problem now is the platelets. And the only thing that doesn't merge well with that we have to explain in a minute or two later is, why is the patient have a low O2 sat, and why does the patient have crackles? Yeah, Lev, please correct me if I'm wrong. I thought the O2 sat was in the 89%, or is it 98%? 89%. So
okay, yeah, that changes.
Yeah. And so we can explain that in a second, but I think focusing on the platelets is really important. So the first question is, does the anticoagulant affect the platelets? And the answer is no. The anticoagulants work on the coagulation cascade, and in most patients they perturb it in a qualitative way, not a way that we can measure with the usual PT and PTT. Sorry, I misspoke. The anticoagulants, especially direct 10A inhibitors, influence the coagulation cascade, but often in a way that we don't usually measure in the PT and PTT. So, and Yaz, you were making some important points about adherence issues and aggregation issues. Those are usually platelet qualitative disorders, meaning that if you would count the number of platelets, the number is totally fine, but their function is impaired. So thankfully, we don't have to entertain those disorders too much when the platelet count is 0. And I think you said the most important thing, which is when the platelet count is this low, you should really think about antibodies to platelets. But if you're thinking about a platelet issue, you first have to make sure there aren't 2 things going on. As you said earlier, you have to look at the blood smear to make sure there's no schistocytes, to make sure you're not dealing with a microangiopathic hemolytic anemia, and you have to look at the medication list, because patients with heparin exposure can have a really, really bad cause of thrombocytopenia hit. And Yaz, I see you typing in the chat. So von Willebrand's, uremia, and paraprotein, those are not disorders of platelet number. So they wouldn't cause your platelet to be low. Those are all disorders of platelet function. And I think that's a common thing that we should try to clarify. So your platelets can stop working because they are normal in number, but they're asleep. Or they can stop working because there are not enough of them. And so common causes for platelet dysfunction, despite a normal number, are medications like aspirin, uremia is a big one, and as you said, paraproteins. Now we're solving a different problem. The problem we're trying to solve is a disorder of platelet number. And the most common cause of a disorder of platelet number this bad is antibody-mediated thrombocytopenia, or ITP. But the question is, Yaz, what do you think? How are you connecting it with the lung stuff? How does that fit in with you?
For me, thinking if anchoring on ITP, which has a wide variety of presentations from asymptomatic to very, very intense gastrointestinal, genitourinary, CNS issues. Actually, lungs is something that also I had been thinking, why would these basal crackles be present? And honestly, the only thing I would see is maybe there's bleeding, because I am very lost on this.
Yeah, I think so too.
Our lungs crackling.
Yeah, I can't think of any other common explanation except we know this patient is bleeding in his legs. He's bleeding in his nose. Why is he not bleeding in his lungs? Or he may have swallowed the blood from his nose into his lungs. Yeah, I can't think of anything else too. Yeah, Lev, sure. Take it away, please. Okay, it's a CT scan. All right, for the sake of time, I'll take a crack at this, Yaz, and then you can take the next aliquot. What I see here reflexively is a right greater than left pleural effusion. And I see bilateral ground glass opacity. So there's ground glass opacities in the left and right lobes. And I'm looking at the heart side. I don't see anything in the mediastinum that's very prominent. But yeah, bilateral GGOs, which can be either blood, pus, or water. And in the context of the bleeding everywhere else, I would worry that it might be blood, especially with no platelets, as Yaz astutely picked up. What was your read, Lev?
Yeah, definitely. And I was not sure, but it looked like bleeding, although I had the same reflex as I think Leah here, the diffuse alveolar hemorrhage, something that is causing bleeding in the lungs. But then again, I am dumbfounded in this moment. Like after lungs.
What was your read, Lev?
This was a great learning point for us, because our team talked about exactly what you guys talked about as like the GGOs or the crackles of the CT scan, and there was an alveolar problem. But we were trying to figure out, does this person have some sort of autoimmune vasculitis syndrome that would lead you to use the word diffuse alveolar hemorrhage? Or is this a bland hemorrhage, which is literally just you don't have platelets, and so you're just leaking into the alveoli? Both of them are diffuse, and both of them are alveolar hemorrhage, but one is due to inflammation, and one of them is due to the inability to clot. And so ultimately, after a couple of days, and we'll get over that, talk about that later, but we probably thought that it was probably just a bland diffuse hemorrhage because of the inability to clot, rather than some sort of inflammatory autoimmune process causing capillaritis or something like that. So ultimately we landed on this is literally just blood oozing into the alveoli, or it could have been just drops of blood from the nosebleeds falling into various places in the lungs as well. And that's impossible to say which of those actually caused it.
Yeah, no, I thank you for reinforcing the idea that you can bleed in your lungs from just having no platelets. and that it could have come from the nose. I think for the sake of time, maybe you can just tell us what the peripheral smear was, and then we can try to come up with our final diagnosis or guess at a final diagnosis.
There were no schistocytes, there were no spherocytes, and otherwise a normal smear, but lacking of platelets.
So yes, what do you think? Thanks, Lev. What do you think?
If it's normal, my next question would be, did they do any platelet aggregation test on this patient? Because if there is no schistocytes, the blood smear looks completely normal. I have now 3 options, like the 3 main players would be ITP, Bernard-Soulier, or Glanzmann thrombasthenia, because those look totally normal on blood smear. Although if this patient had Bernard or Glanzmann, I would have thought, well, maybe he had another episode bleeding before, because those are normally like found in way earlier in life, not at 90 years old. So that would be my next question. Does this patient has platelet aggregation testing? And if it's normal, then I would see ITP. Those are my differential diagnosis, because diffuse alveolar hemorrhage, it's caused by a myriad of things, from vasculitis to coagulopathies to infection. So yeah, like thinking, I rather think first what's going on with the platelets.
Yeah, I think the platelet answer is in the platelets for sure. And I appreciate you pointing out that the age here is really important. Of course, I think ITP is definitely a disorder of older adults. Correct me if I'm wrong. I think I haven't thought about pediatric conditions since medical school, but my working understanding is that Glanzmann and Bernard-Soulier would not show up with a low platelet count. They would show up with low platelet function. What is your understanding? Yes.
I believe, and again, I think that Bernard is the one that has low platelets, while Glanzmann will look normal. But Bernard-Soulier will have low platelets and giant platelets, while Glanzmann thrombasthenia, we call it the sticky platelet syndrome. So that's why I would ask if there is a abnormal aggregation. That's the difference between both of them, because one and ristocetin assay too, because one would have abnormal ristocetin, which I believe is Bernard, and Glanzmann would have a abnormal platelet aggregation testing to confirm the diagnosis. But yes, I thank you, Ricardo. I see that in the chat that I was all right with that, if my memory is not wrong.
Yeah, no, your memory is clearly phenomenal. well more advanced than mine. I will share with you that there was I'm glad I was a little ignorant, because sometimes not knowing things helps you get to the answer, because my DDX of platelets is much simpler than yours, and it's large part because I know nothing else can cause a platelet count of 0. Literally no other diagnosis apart from ITP. And I think that's the key part of the case, is when you have undetectable platelets, 99% chance of ITP, but that doesn't mean the diagnostic journey is over. You have to be careful, because Yaz, as you said, Yaz, these are antibodies. And the question is, does this person have primary idiopathic ITP, or does he have secondary ITP triggered from a variety of infections, autoimmune conditions, or cancers? And I think that when you have ITP in an older patient like this, you have to worry that they have developed secondary ITP. And yeah, there are many, many things that can do it, including CLL. But I'm really curious, Lev, how you all, what your diagnosis was and how you were thinking about this case.
Yeah, so I'll finish up, yeah? Okay, Heme saw the patient on day 1, and given their high concern for ITP, started the patient on IVIG and IV steroids. And I learned that although it's not fully known, a part of the problem with ITP is that the antibodies bind to the platelets and then go hang out with the macrophages. And so what the steroids were, and this was a learning point for me, is actually in some ways a macrophage eliminator, destroyer, if you want to think of it that way. Because I was like, I understood that the immunoglobulins may bind to the incorrectly destructive antibodies, trying to not destroy the platelets. And his next day, his platelets bounced up to 40. And everyone felt like, great, this is probably ITP, since the treatment for ITP is working. And then the next day they went back down to 8. And unfortunately, there was a roller coaster of platelet things going on. And eventually he was actually started on a medication called N-plate, or a TPO agonist, to try to boost the bone marrow's ability to get the platelets up, despite the fact that things were getting destroyed. And he was on a platelet roller coaster for many days, but thankfully his bleeding sort of stopped. But eventually, because they were concerned of secondary ITP, he ended up getting a bone marrow, and thankfully he had no myeloproliferative disorder or anything else that was caused it. So we never actually figured out the cause. And maybe, I think he had had a URI at some point and had gotten some vaccines a month ago. And maybe that was the trigger, but we ultimately never figured it out. And as a curveball to the case, at some point his bili ended up rising, and we ended up getting a direct a Coombs test, sorry, I forget what DAT stands for, and it ended up showing an IgG positive on the DAT. And then the curveball here was like, we were like, oh, did he actually have two cell lines that had things going on? But ultimately, his bili went back down to normal, and we decided that he had antibodies to red blood cells, but wasn't actually hemolyzing from them. So this wasn't Evans syndrome. And so he ended up ultimately getting a diagnosis of ITP of unclear cause, and eventually was able to leave the hospital after multiple days of treatment.
Wow, that's an absolutely incredible case. Thank you, Levin. Yeah, I think this is a great reminder that sometimes, one, the testing for platelets, autoimmune platelet disorders is very, very limited. And demonstrating autoimmune phenomenon to the adjacent red blood cell can be informative. I'm curious, what was your biggest takeaway and learning from this case, Lev?
I think as a hospitalist, I was just concerned about his airway and his breathing the whole time. Yeah. And it seemed like a ticking time bomb type of situation where I was, But I think from an ITP perspective, it was learning, and our sub-I who took care of the patient did an amazing job teaching us about ITP and realizing the roles of IVIG and steroids, and then the N-plate, and why we actually do those treatments rather than just doing what heme says to do, and trying to understand the mechanism of this, which super cool.
That's so cool. You're such a great, such a fantastic, it sounds like a fantastic learning environment where you're getting input from experts, one of the world's experts probably, but also an opportunity for an early learner to shine and grow and explain things. That sounds so enriching and cool. Yaz, how did it feel to discuss some heme today with Lev?
It is amazing. Actually, how interesting is that yesterday we also had an Evans syndrome case.
Yeah, I know.
I had never thought about, I was so anchored on the platelets that this patient is also anemic. So Evans syndrome, from what I understood from yesterday, was that it's cytopenia due to this IgG's antibodies destroying RBCs and destroying platelets. And it's very interesting. Actually, I'm thank you, Dr. Lev, for bringing a case. I hope that everybody that is here, before I forget, like if you want to bring a case, it doesn't matter how interesting or not, quote unquote, you think it may be. Every single patient we see has something important to teach us, and I will definitely not I will never oversee this cytopenias ever again, because it's very interesting and useful. Thank you.
I love it. Yes, thank you so much, Lev. It's always a treat when you're here. Welcome back. I hope we get to see you more often, and hope next time you can sit back, relax, and nerd out with us. But I appreciate you bringing the learning this time. It really means a lot. And unfortunately, I have to get going to work. So I made you, Leah, the host. So I'll pass the mic to you to take us home. Just remember to close the meeting at the end. Otherwise, the YouTube recording will be filled with your your camera view at the end, which I've done many times before. All right, y'all. Thank you. See you next time.
So yeah, I will do the teaching points. Thank you, Lev, again for sharing this case. So I think there are 3 big learning points to take away from this case. One is what we can do when someone is bleeding out of their mouth. And then 2, in general, how can we approach a person who is bleeding diathesis? And then 3, what to do when the platelets don't function or are low. So I think let's start with the first one. So we have a patient who had bleeding out of his mouth. So we kind of first started to think about hematemesis, which is bleeding out of the GI tract. And there are many causes. We thought of peptic ulcer disease, traumatic causes such as Mallory-Weiss or liver disease. And a helpful approach could be dividing that up into variceal versus non-variceal bleeds. And this is this can be a situation where it's more important to treat before you diagnose. So make sure the airway is protected or do all the necessary preparations in case blood transfusions might be needed. And then just a step back, because bleeding out of the mouth doesn't always have to be a GI bleed. It can also be out of the lungs. So it could be hematemesis or an upper airway bleed, or is it actually blood, or might this be something else? These are questions that you can ask yourself. And then we talked about, as Jazz pointed out in the beginning, you need to characterize the rash. And we found that the rash the patient had looked a lot like a petechial bleed. And a way to differentiate purpuric and petechial is by the size. But I think both are usually non-blanching because they are bleeding. And you can also, a clue that was shared, feel it if it's palpable or not. This could indicate that this might be purpuric or purpura. And now to take a step back, the point 2 I mentioned was bleeding diathesis. So how can we approach a person who is bleeding more than they should? It could either be a blood problem. So is it something with the coagulation or the platelets? Or it could be a vessel wall problem. And that would be an example where we find a palpable purpura. And in this patient, or this case that we saw today, the patient had a very low platelet count, but there is not only quantitative problems with platelets, so thrombocytopenia, you can also have a qualitative problem. So somehow the platelets are there, but they don't function properly, and you still bleed because they don't do their job as they should. And examples that can cause a qualitative problem are aspirin, uremia, and paraproteins. And this case, we had an ITP as a diagnosis, which is a cause that a cause of a very low platelet count. So this was quite remarkable here. We had a platelet count of 0, and this was very indicative of ITP. And with ITP, you should always think, is it primary or secondary? And also with the age, we thought or were concerned about secondary ITP. And I just want to finish with a sentence that I really loved. It was, Lev mentioned that ground glass opacities can be called crackles of the CT scan, which I think is such a helpful way to think of it. And then another learning point from this case was like the distribution of the bleed was diffuse, yes, but was it just hemorrhage because of the platelet dysfunction, so bland hemorrhage because of the inability to clot, or was it diffuse alveolar hemorrhage, which we typically know from inflammatory diseases that cause inflammation of the small capillaries. Yeah, and I want to end with that. I put the 2 names of the rare diseases that Jasmine also mentioned on the board if you want to read it up. And thank you a lot. I learned a lot from the discussion. Thanks also, Lev, for bringing this case. And I'll finish here and see you guys next time. Bye.